Yeah, thank you. Yeah, we're recording now. So, yeah, thank you very much. Over to you.
Perfect. Okay, so tonight's session is going to be a little bit of a mix in terms of what's going to happen. It's going to be a bit of a quick summary in terms of the key elements of discharge medicine service, and then as well some of the more points tailored towards mental health and psychiatry. Okay, so in terms of some of the stuff that we'll be looking at, it's some of the more like key principles in terms of when the service first launched 3 years ago, and then kind of getting an idea in terms of where the pharmacist fits into this bigger picture, and then how we sort of tailor our conversations towards this particular patient demographic. Okay, so if I'm just going to do a quick overview in terms of discharge medicine service, so it was launched February 3 years ago as an essential service. The key idea being to that NHS trusts, whether that be an acute trust, whether that be like a teaching hospital or like a specialist area, like for example ourselves in mental health, or perhaps even like the Christies, that these sort of groups could have sort of like a direct means of supporting post-discharge care using the community pharmacy. And it fits in terms of the wider elements in terms of NICE guidelines, where the medications post-discharge should be reconciled within roughly 7 days, and essentially prevent medication-related harm and prevent readmission of the patient. Those are sort of the key ideas. Um, so in terms of changes in medication, what we tend to see is that Uh, on average, about 60% of patients have about three or more changes to their medicines during their inpatient hospital stay. But contrary to that, it also has unintentional changes. So anywhere from 30 to 70% of patients have, whether that be a missed medication or something that's started and not stopped at the point of discharge. And then when we look at our more vulnerable patients, like our older adults, 90% of them will have some change, some significant change. And what can happen often is medication started towards the end of a patient's inpatient journey. So maybe that might be the last couple of days, that final week, depending on the setting that they're in. And some of these could be preventable. If I show you some of the like inpatient stays that we have, for instance, in our trust, it can range from like a shorter admission, so maybe 7, 10, 14 days. But then as well, there are some more prolonged admissions where there may be many months because with a lot of treatments in psychiatry, the best effects for some of them don't necessarily take place for around 4 to 6 weeks, perhaps, if we're looking at the likes of our antidepressants, or if we're looking at certain antipsychotics, they may not reach their steady state until about 12 weeks of continuous use. Now, in terms of what, if I'm just going back to the purpose of the actual service, key ideas are more to do with preventing harm, improving the patient's understanding of their medicines and their regime, and maintaining sort of the stability that we sort of try to achieve towards the end of someone's inpatient stay. And part of that involves a better transfer of information, more communication, more input, and that's where we're kind of looping in our community pharmacy colleagues. Um, if we're looking at it in terms of like sort of a pathway, you've got a lot of access to information when you're looking at the hospital setting, in a general in GP practice. However, in terms of how much information a community pharmacy may have. It may be quite limited. It may be very limited dispensing records. It might be, for example, the patient's only using the pharmacy for, say, for example, their methadone or buprenorphine, for instance. So some of this is more to have that sharing of information, that improved support, and better aftercare in terms of their treatment. So, in terms of the actual stages themselves, what's actually completed in a community pharmacy, there's sort of three key elements. So the first bit is more receiving the referral and having that, and this is at the point of maybe 24 to 48 hours after someone's been discharged. And what that kind of helps to address is there any old prescriptions that might be sitting on the shelf? Are there any key changes? What sort of things should I be expecting from the next set of prescriptions that I'm getting? So that leads me on to the second stage when the first prescriptions have come. So when those first prescriptions have come, uh, we're probably anticipating um, anticipating a similar profile in terms of what we've just seen or what we've read on that discharge letter. Um, Now, if I'm going back to stage one again, some of that might be picking up on what has perhaps been missed in the medicine reconciliation, the clerking process when someone's in hospital. So that might be helping to fill in some of the gaps, maybe questioning, querying the inpatient team. Um, so then when we get to stage two, when we've got the prescriptions, we've kind of like filled in the blanks and sort of built a bit of a picture in terms of what our patient should look like in terms of their health, their medication at this particular point. So then finally, in terms of stage three, that's when we're having those remote or in-person consultations, getting an idea as to how well does the patient understand the medication regimen? Are they having adverse effects? Um, is perhaps somebody else involved in the care supporting them? Like for instance, there may be carers coming in, there may be family coming in that might be supporting to make sure that those patients stay well and hopefully not having adverse effects, or if they are having adverse effects, being addressed appropriately. So, in terms of what that sort of might look like. So you might see, for instance, that it'll include in the EPS tokens, perhaps that there's been a letter that, or they might refer to the discharge, or they might refer to, because, for instance, in Greater Manchester, our first and second generation antipsychotics, they're subject to shared care. So they might be awaiting or they might have prescribed only starting from that shared care, that shared agreement of prescribing between the GP and the specialist team. Okay. And what we might do is we might look at those patients that may be more vulnerable or that we've identified early in the admission that it might be medication related harm that led them to coming into hospital, and that's how we can support them better. It might be perhaps, for example, there's a compliance aid that's involved, and there may be huge, like quite significant changes. Like I mentioned with our older adults, only 10% of them will be on the same medication regimen as they were when they first came in. Okay. So in terms of what what we hope to see from myself and other pharmacists in the community, which is more a case of having that embedded, integrated approach. So supporting our primary care teams in terms of flagging and identifying the key issues in terms of um, what things may have been stopped in error, or what sort of things that we should be expecting from the new prescriptions when we are completing stage two, or what about might have been missed when those prescriptions have been issued. And then the bigger and, in my opinion, the more important element is the supporting the patient element. So, does the patient understand what they're taking now? Do they understand why they need to keep taking it? Do they have an understanding in terms of perhaps how long they might be on that treatment for? Because, for instance, some treatments are started and they may have perhaps a stop date or a recommended stop date in terms of NICE guidelines. However, what can end up happening is that patients end up on that same treatment for months and maybe even years. And then as well, some of the more holistic elements, so a healthy lifestyle that comes along with it. So, for instance, if we look at in psychiatry, a lot of patients are started on um, antipsychotics. So some key ones may be clozapine or olanzapine, where they have a huge impact in terms of patients' glycemic control, and as a result, maybe later down the line from when they start, when they're still on this medication, that they've developed diabetes, unfortunately, and so part of that might be counselling and support in terms of good diet choices, the importance of like regular exercise, and how the patient can actually realistically build that into their life. Okay. Um, so some of the more general considerations. So with regards to things like the final stage, stage three, there can be remote consultations. A lot of referrals that are sent out do include um, maybe some contact details or who best to contact to support and have that conversation in terms of uh, that final stage in terms of understanding adherence, supporting the healthy lifestyle, um, making sure that the patient understands their current medication regimen. Um, but as well, the other element is that it doesn't necessarily have to be the same pharmacy as well. So, for instance, at the minute, my current rotation is in old age psychiatry. And so the patients that I see are more, for example, dementia patients where they may end up, for instance, in a nursing home or a residential care home where they may stay long term. And as a result, that care home may only have patients registered with a certain GP and only operate through a specific pharmacy. So the pharmacy that might have initially received the referral may not necessarily be the one that they're going to be having prescriptions sent to, or the one that's going to be nominated. So in terms of how much they can do, it limits it at perhaps the first stage in terms of identifying discrepancies. But in terms of stage two, they probably won't receive prescriptions. And in terms of stage three, they can't really counsel someone that's no longer going to be in their care. So there is an additional option in terms of, okay, DMS2 not completed. Why not completed? Patient change pharmacy. New pharmacy is F code and the onward referral. Okay, but because there can be such a high volume of referrals that are received, it is critical that those specific pharmacies do have their own operating procedures, their own process in terms of, okay, such a referral arrived on this date, it referred to 7 or 14 or 28 days of medication. I should expect a prescription at this date. And if not, what am I going to do? And at what point will I close or no longer continue the service? Those sort of elements. Okay. So if I'm going to focus more now on like mental health services that we have, and that is generally what we see in England in this particular area, the Northwest and Greater Manchester. It's sort of divided into a few key categories. So if I'm focusing on more on inpatients, it'll be more or less adults, older adults, and then your CAMs. But then under those, you might have specific groups. So, for example, with adults, you might have, like, for instance, in Greater Manchester Mental Health, we have like a what you might have heard of it, Chapman Bark Unit, where we have patients that go in for detox and support with substance misuse, as well as looking after their mental health. Um, and then if I'm looking at more, for example, in terms of outpatients, there's our community mental health teams that may go out to patients, or maybe the first point of contact in terms of someone being referred from their GP, for instance. And then there's some of our more specialized teams, like our crisis and home-based treatment teams, that are supposed to be their purpose is more, okay, we know that this patient is prone to relapse. This is the sort of intervention we're going to try and make, and this is the sort of support we're going to be giving. And part of that might involve, for example, where we do our outpatient and community clozapine titrations. Okay. So some of the things that you might notice from, you might have noticed that we started sending out referrals like towards the end of summer this year, and some of these might have specific diagnosis that people have picked up on, or certain medicines that patients might have been picked up on. And for some professionals, they may not necessarily have um, much experience or much contact in terms of, okay, what is this presentation going to look like? How's this patient going to, how is this patient when they're well, and how's this patient when they're unwell? What sort of treatments might I expect? Um, what sort of combinations may I expect? What sort of medications may be dealt with by a specific team? Or, um, like for instance, if I'm focusing again on clozapine, clozapine is in Greater Manchester a red drug, so it will always be prescribed by a specialist service. So there will never be that expectation for shared care prescribing, for instance. Okay, so if I'm gonna focus more on some of the medications that might be coming up on some of these letters and referrals, you may be seeing certain medications like, for example, pirenzepine. So pirenzepine in this country is actually not licensed, but it is one of the options that are considered for hypersalivation. It's not the first choice, but it is one of the treatments that we do see is quite effective. It was historically developed as a treatment for duodenal ulcers, but then over time, more safer and less cholinergic drugs came about. For example, like proton pump inhibitors, like your omeprazoles and your lansoprazoles. And then, for instance, you had your H2 receptor antagonists, like your cimetidine and your famotidine and ranitidine, and then obviously that was taken off the market. That's a whole other story that I won't delve into. Um, so there'll be certain drugs that you see that might not necessarily be on those EPS prescription, on those FP10s. So, for example, olanzapine. So, a lot of your depots, there's a lot of primarily patients would go into a depot clinic, or maybe a community nurse practitioner may come out and administer the depot in a patient's home. But one of the more rarer depots that we see is something like your olanzapine depot, which is significantly less commonly used, primarily because of that risk of post-injection syndrome. And in terms of practicality, that could set in in any of the injections that they have, regardless of if it's the first time or the 15th time. And there is that risk of it setting in within the first 3 hours of treatment. So in terms of practicality, um, there are less clinics that would facilitate a olanzapine depot because the patient would require regular monitoring over the course of 3 hours. And then you've got some other less commonly used, somewhat more expensive treatments like your lorazepam and your cariprazine. Um, and then, for instance, there was an interesting conversation I had with one community pharmacist where even though vortioxetine's been out for quite a few years, it was the first time that they'd ever co come across it. So I was kind of highlighting to them, okay, this is the sort of treatment that it is and how it works and why it's probably less commonly seen, but it does have a place in treatment. And it is something that the GP will end up prescribing, and sometimes some GPs do initiate. Okay, so briefly touching upon NICE guidelines in terms of medicine optimization and why we are focusing on this discharge medicine service and the need for medication reconciliation review. But key element is that patients need the best possible benefit from their medicines and where they can. In terms of when patients transfer from one care setting to another, whether that be, say, for example, if I use an example, Salford Royal to Woodlands, and then shortly after Woodlands, they go home. There's two key jumps and a lot of information that may come to the GP, but in terms of what that community pharmacy might see, they might see, okay, this is what they were on before, this is what they were on at the point of the Woodlands discharge. These are the sort of changes that I'm expecting. Um, this is what I'm going to notify the local GP about, and this is what I should be expecting as part of stage 2 when I receive those new sets of prescriptions. Okay. So I'm sure this is the element that I think you're most looking forward to, which is the consultation skills and some of the challenges that you may encounter with this particular demographic and this particular patient group. So in terms of some of the training that's available and that can help to support, there's quite a lot in terms of on the CPPE website in terms of supporting some of the more basic consultation skills and how we support patients and how we counsel appropriately and what sort of things that we try and aim for and the various models that can be used to support. And then there's the elements of what sort of things might come up when we have these discussions. So will there be conversations perhaps around adverse drug reactions and how do I get familiar with them? How do I understand, okay, this is what extrapyramidal side effect is. This is what this patient's experiencing. What sort of medication might I expect? What can I do about it? How can I escalate these sort of things? But then, for example, there may be patients that are more not necessarily benefit from the medicines. So they might be presenting with anxiety. They've received a medication for their anxiety, but it's not quite having the impact they're expecting. So part of that may be helping to support with realistic expectations and understanding, okay, this is when the medication is likely to work. And then more in general, so some of the more crisis type situations where someone may be at rock bottom, where they're potentially considering maybe harming themselves or someone else in like the close vicinity in terms of how we can um, support and escalate appropriately. Okay. And that's where some of these resources come in quite handy, particularly there is quite a sizable CPP module which touches upon some of these components separately. So things like anxiety and like the more sensitive consultations that you might be having, but as well having that confidence to discuss and like supporting the patient opening up in terms of, okay, how are you feeling right now? Have you had thoughts to harm yourself? Have you made plans to harm yourself? What does that sort of look like? So that helps to build a picture in terms of, okay, this is what could potentially happen next. Okay. But some of the key elements that we want to focus on is more around having, demonstrating the empathy and understanding that, okay, such a situation might have set this off, whether that be, and that's more understanding some of the social elements of a patient. So, for example, um, might be a financial situation, it might be, for example, a change in relationship, sort of getting an idea in terms of what's happened, how can I support, whether that maybe just be purely listening, and providing that sort of validation and having that non-judgmental approach to understanding, okay, what's happened, what's going on, okay, but then as well having that confidence to ask the harder questions. Okay, now this has happened, you've told me this, what are you going to do next, or and what's your plan in terms of, for example, okay, you've lost your job. Are you going to be job hunting? What sort of plans? Where do you think you might be looking at working, for example? So something simple like that. But then as well, some of the more difficult questions about um, things like self-harm and suicide. Okay. And if necessary, signposting. Well, not if necessary, more necessarily signposting, because in that environment, in that perhaps community pharmacy environment, you might not necessarily be equipped, okay, to provide the level of care that the patient might need at that time. But it's knowing in terms of where the patient can go next, who they can contact, or if they are at perhaps crisis point where they are needing to perhaps consider, emergency services and A&E, those sort of settings. Something that I use in my like day-to-day practice is this model, the consultation hill. So what I try and aim for is I try to have a bit an idea in terms of what I'm going to be discussing, and in my mind a little bit of a structure in terms of the start and end point. So part of that involves a little bit of an ascension in terms of gathering information, and certain consultation models, for example, things like your Cambridge Calgary consultation, might be Calgary Cambridge, might be the other way around. Focus on, for example, starting with open and broader questions, and then using things like narrow and closed questions to sort of pinpoint and kind of get an idea in terms of what's going on. But a lot of that involve some of the models include what's known as the golden minute, where there is that minute of patient just explaining and being listened to for that uninterrupted minute, um, to hopefully gauge what's going on and um, or what sort of experiences they might be having. So, for instance, today I was having a discussion with a patient surrounding some of the adverse effects of their Depakote, because Depakote is quite commonly used in bipolar affective disorder. It's quite commonly used as a mood stabilizer. Um, so some of the so I gave them that opportunity to discuss and highlight to me some of the adverse effects. But then as well, this shared summit element, if I continue to allow that ascension, then what might happen is a bit of a tangent, or like numerous issues which may require addressing separately to be springing out. So what I try and do is try and like pinpoint and get to a point where I'm saying, okay, so you've been experiencing, for example, this rash or loss of hair or upset stomach or like diarrhea, for instance. And then we kind of get to the point where we have a discussion in terms of the strategies and um, like a time span in terms of when that's been going on, and then get to more of a descent in terms of, okay, this is the plan, this is what we're going to do about it, and if things are not getting better, then that's when we will review the situation and perhaps think of a new plan. Okay, but as part of that, I might reflect in terms of, okay, these 4 or 5 symptoms came up. I might need to have a separate discussion in terms of addressing what those issues are, how likely those adverse effects are, and how we can develop a new strategy to resolve them. Okay. So if I'm going more in terms of signposting, so particularly in Greater Manchester, there are specific means and ways of patients helping themselves or highlighting how perhaps help can be sought. So obviously we might consider the likes of general practice, our GPs, and our mental health teams that they may signpost to, or they may be under an existing mental health team. But then as well, if it may be first time presentation out of hours, perhaps services like particularly 111, which most recently involved um, I want to say integrating the mental health crisis line within it, so that it's more tailored towards those specific patients that are in crisis and need support. But then, if it's at the point where we think, okay, there's going to be huge risk to themselves or others, that's when we might be considering the likes of your accident emergency and your ambulance service to support. What might be noticed, for example, in like near motorway bridges, is that you see like the phone number of Samaritans available to contact if necessary uh, at that point, at that particular crisis point. Okay. But then as well, there is still the key like safeguarding elements. So part of what might have led to the presentation or the current situation may be um, perhaps an abusive partner or family member or um, like carer or neighbor, someone involved in perhaps contributing to this current presentation and state. So that's when we have to think outside the box in terms of, okay, this might be, or this looks like domestic abuse. This is who I'm going to contact or who I'm going to support the patient in contacting. Okay. As well, some of the focus may be not necessarily on medication. So, in terms of what's available for patients, there is the NHS talking therapies, and that includes certain elements of cognitive behavioral therapy, and that can help to support with getting an idea in terms of helping our patients understand their condition better and how they can live and work and have a family, and factoring all these things in whilst they're experiencing the symptoms that might be quite intrusive in their life. So that's something that patients can self-refer to, as well as GP referrals as well. Okay. And then just finishing off more towards the actual support helplines that are available in and around Greater Manchester area. But as well, there is the element of looking after ourselves, looking after our fellow pharmacists, in which case, depending on the setting that you're in, you might have a supervisor, you might have a partner, perhaps if it's an independent business. So there are those opportunities to discuss those specific situations and um, themes that are noticed in terms of, okay, I'm having more patients that I've recently had a diagnosis of schizophrenia. What does that look like? How can I support and build some CPD and improve the quality of care that I can provide? Okay. But then as well, some of those situations might be incredibly stressful. So certain, for example, safeguarded situations, you kind of go away from the situation thinking, was enough done? Will the patient perhaps access the care that I've advised them to? And some of that might help in terms of discussing with someone else, particularly a supervisor, another professional, another pharmacist, maybe in terms of um, understanding situation and what was done and how it could be done a little bit better. So it's just some links and some resources that can be used to help support and develop some better well-being, particularly in the high pressure, stressful environment that is healthcare and community pharmacy. So I'm just going to make a final note in terms of the volume of services that are actually done by community pharmacy. So if we look at some of the key elements, so I've used on the left an example pharmacy, and then I've compared that in terms of a national average. So in terms of on average, a pharmacy in England does this. So if we're looking at that, we can see, for instance, that um, on average, the average pharmacy does approximately 5 to 6 discharge medicine service claims. And that tells me that there's been those 5 or 6 patients where they've accessed and been involved in the service and could benefit from the support that is offered and have potentially benefited in preventing a readmission. But then, as well, in terms of looking at all these other services, we spend a lot of time in terms of, for example, NMS. NMS is the key element here because there's a number of conditions where we support them in understanding the medication, understanding adherence and adverse effects. And if there's a need for escalation and referral, okay, my patient has started amlodipine recently, and within a few days they've developed ankle swelling. That's when, for instance, we would be escalating and highlighting to the patient, okay, this is quite a significant adverse effect where uh, their healthcare professional is likely to change their medication as a result. Okay, but then as well, we do have those services, for instance, like your urgent medicine supply. In addition to NMS, where we're doing those remote consultations and helping to support with, okay, this medication as you run out of, this is quite critical because of this. Say, for example, it's a anticoagulant, and understanding sort of the consequence of misdose and counselling and educating the patient in terms of why it was more important or essential that they ordered their medication in a more timely manner. So we are already having those conversations around health and medication and that post-discharge support already. So more of it now is going to be because of might factor in, for instance, conversations surrounding a new antidepressant or a new antipsychotic or um, a new anti-anxiety medication that might have been started and how it's best to use it and what sort of adverse effects and what benefit we are likely to see. So if I am concluding there. I'm going to open up the floor for any questions.
Hi, sorry, I'm not sure if you can hear me. Can you hear me now, Louise?
Yeah, I can hear you. Yes, I
Oh,
can.
brilliant. Right, great. So wasn't sure what was going on with the sound going out there. Thank you so much, Devin. That was fantastic. That was brilliant. It's very good to have been able to record that as well, so we can send that around to people. That was exactly what we were looking for. So thank you very much for your work there and putting that together. I know we've been asked already about sharing both the recording and, of course, the slideshow as well. So, yeah, if you could share that with me, then we can get it sent round as well.
Sure.
Louise, thank you. Louise, yeah, do you want to come in?
Yeah, got a couple of questions for you, Deven. Thanks very much. I really enjoyed that. I found it quite interesting. I suppose thinking from a GMMH point of view and from patients with mental health problems, how much do they know about their medicines when they're discharged? Have they got a good understanding, or is it a bit of a mixture? Or I'm just wondering how much information they're provided with, in terms of counselling before they're discharged.
So it does vary, and it varies for a number of reasons. So, for instance, I think the key element is, for example, I think the key factor is the length of the admission. So, for instance, there may be certain circumstances where we've started a medication or started multiple medicines in a short time frame, and they've presented with a level of stability, and that morning, okay, we're discharging them in 2 hours. So there's a lot of rush around in terms of um, destination and arranging discharge medication supply. So at the point of discharge, there probably is maybe not a lot of counseling and support for that group of patients. But for instance, if I so uh, on one of the sites that I work at, they have what's known as a self-medication strategy. So on the inpatient ward, we already start trialing the patient self-administrating the medicine and perhaps a nurse observing and supervising. And that particular patient may will probably have had their medicine. They've probably been on a stable medication regimen. They've probably uh, got a chart to help support them. They've probably had various professionals, including a pharmacist like myself, that's kind of explained, okay, this is what this medicine for. This is a when needed medicine when you're experiencing this symptom. For example, um, if I'm using paracetamol as a when needed medicine, but then as well, they may be on, for example, a regular dose of mirtazapine at night. So they'll have that understanding that it is to help support and, improve their mood. So to answer your question, it does vary from patient to patient. Um, I tend to see that the patients with more prolonged, slightly more prolonged admission probably have a better understanding because there's been more opportunities for those discussions. So, for instance, the way I sort of work is I will probably see 90 to 95% of my patients within 24 hours of their admission. Um, and perhaps I might identify that a new medication has been started along that way. So I'll provide some counselling and some resources. And as part of that, we would use resources like choice and medication, which uses like basic information leaflets that are tailored and don't bombard patients with a lot of like scary information. Okay, you might develop 20 adverse effects as a result.
Thanks, that's really helpful just to understand. And I suppose when you're thinking about those patients that are only in for a short amount of time
Mm.
and that are discharged quite quickly, will they know their diagnosis? Will they know what's actually wrong with them? Or will they not? Because obviously we may see things on a discharge letter, and then be speaking to a patient about it, but if they don't have a full understanding of what's wrong with them, I just wonder how that might.
I certainly think there is some understanding because, particularly in our trust, we have a 72-hour rule where they'll be reviewed and seen by a consultant. So I think probably at the point of admission, they'll have clerking. They will have a medicine reconciliation where a pharmacist or a technician might understand their medicines and help to support with that. And perhaps later down the line, they've got that 70-hour review, and they may have perhaps additional planned reviews to have those discussions and be made aware of their diagnosis and what's being treated and why the purpose of their admission.
Thank you.
So I think there's definitely points where patients know and understand what's going on. However, some patients might not necessarily have the capacity to understand early on.
Okay, thank you. That's really helpful. Thanks.
Great, thank you. Donna?
Hi, just to add to what Deven was saying there and to answer a little as well to the question that you've asked, some of our patients that are on a quick turnaround have been admitted because they're in crisis of a condition that they've already got. So if they've got the understanding, it's just maybe looking at the doses of medication and changing them, or they may not have been taking their meds in the first place to end up in the crisis in that short turnaround period. The other type of patients that we potentially will be sending DMS services out to the community are our planned addiction patients. So these are planned admissions. They're stayed in for a certain length of time. They're in a lot longer. So they, as Deven said, will get counselled by the ward pharmacists, the technicians and the nursing teams within the ward. So again, they have a good understanding of what they're being discharged with.
Thanks, that's great to know. I suppose I've got one more question then, and just to add on to that one. When you're sending a DMS out to a pharmacy, does the patient know that you're sending it? Are they aware that are they expecting a contact from the pharmacy at that point of discharge?
They probably might not be familiar with what might be happening. So, but that's kind of where we're involved. So if we have that opportunity to speak to that patient before they've gone, then we can explain and highlight those things. However, what we have on a practical perspective is a lot of our patients go on what's known as Section 17 leave. So they'll go home for perhaps a trial period. And if they continue to demonstrate the same benefits and stability that we started to see when they went on those leave periods, they may not necessarily get that contact. So they might not necessarily have that opportunity to have to get told, okay, so the Collins that's round the corner, or the Peak Pharmacy that's up the road, or the Boots in town might be calling you perhaps maybe a couple of weeks down the line when your new set of meds have come, or they might be having this chat, or they might have seen your discharge letter and seen what sort of led you to be an inpatient. So where possible, we try and make patients aware that they're going to have some post-discharge support, but sometimes that is not always practical.
Okay, thank you. Thanks, Deven.
And then sometimes as well, for some patients you can, in terms of their capacity might have gone quite significantly. So they might be perhaps, for example, if I'm talking about some of our dementia patients, the call or the conversation might be with a family member, say, for example, wife or husband, son, brother, someone who's living with them, supporting them whilst they adjust to where they are.
Yeah, thank you. That's really helpful. Thanks.
Excellent, thank you. Any more questions from anybody? No?
I do
Okay.
have one more.
Yeah, absolutely.
Apologies. This is not strictly speaking related to DMS, so you may not know the answer to it. But when I work in Bolton, I tend to when I work as a pharmacist, I tend to work in Bolton, and obviously we've got a huge amount of promazine use in Bolton, and I understand that they're going to be doing some promazine deprescribing, and I just wondered if that piece of work has started and how best we can support those patients, or if you
So
know.
I do know actually. So
Oh, good.
that does come in handy. So some of that work has actually started because I do also work in Bolton. So I know some of my colleagues, perhaps, for example, Runworth PCN, if I'm using them as an example, have already started with um, reducing or supporting patients in coming off the likes of promazine. But then as well from our trust perspective, there's been a lot of work over the last, I want to say 12 to 15 months in terms of preventing or reducing the need or the inappropriate prescribing of promazine for two key reasons. The first key reason being is that it's quite inappropriately used as a PRN treatment. And then the secondary, and because it's inappropriately used, I think people forget that it is by its nature still an antipsychotic. So you still have that risk of those metabolic effects. You have that impact on various systems. It doesn't have the best kinetics, so it does have a cumulative effect. And something that I learned during my pre-reg is that the oral solution has a high glucose content. Uh, just to add to that, but yes, some of the work has been going on and been going on over quite a prolonged period in terms of preventing people being started and reducing and deprescribing.
And is it going well? Is it being quite successful with the patients that you started with?
Quite for a significant portion of them, yes, I'd say so. Some of them, because they've associated the promazine as a treatment for their anxiety, when those symptoms start to set in again, that's when there's the key challenge where, okay, I can either continue to reduce, I can use an adjuvant, but the adjuvant may be something like a benzodiazepine, which may be less favorable for prescribing. Or in this particular patient, perhaps even though it's not something I want to do, I might keep it for the short run and revisit the strategy later down the line.
Thanks, Deven. It's really helpful. Thanks for answering all my questions.
Yeah, absolutely. Thank you very much. If there aren't any other questions, I was wondering, Louise, if you want to just speak to the resources that I've shared, the file that I've shared in the chat for Community Pharmacy Greater Manchester.
Yeah, I can do. Yes, we've in the chat. Alex has very kindly uploaded one of our documents. It is just a really simple document with some QR codes on there that you can scan and access resources from Community Pharmacy Greater Manchester, or links to our web pages and some other things. So please do make use of that document. If anybody wants a copy emailing out to them, just let us know and we can send it out as well. Thank you. You managing to share it, Alex? Thank you. That's the document there. Thanks.
That's Deven actually sharing that. So yeah, thank you very much.
Sorry, I didn't realise it was still sharing.
No, you're sharing the right
No problem.
document. That's brilliant.
Okay.
Thank you. That's really helpful.
No problem.
No, that's great. Thank you. Right, brilliant. So yeah, thank you very much, Deven. That was excellent. Thank you for everything. And yeah, if there's nothing further, then I'll stop the recording, and then I'll say goodbye to everybody, so I'll stop recording now.